I think we'll get started now. Hello and welcome to CJJ's webinar, Addressing the Intersection of Juvenile Justice and the Opioid Epidemic with Multisystemic Therapy. I am Laura Armstrong, CJJ's Policy Associate. I want to run through a few technical details before we begin. First, you will notice that all participants are in listen-only mode. This means you are muted throughout the webinar. To ask a question, please type your question into the question box at any time throughout the presentation. We will be answering questions at the end of the presentation. Additionally, we will be recording this webinar, and the recording, PowerPoint, and additional resources will be posted on CJJ's website within 24 hours. I would like to introduce our presenters. Lori Moore, the Manager of Network Partnership and Vice President of MST Services, and Logan Greenspan, the Managing Director of MST Services. Thank you, Lori and Logan, and I will turn it over to you now.
Thanks, Laura. Hi, everyone. I am Logan Greenspan. I am really excited to be speaking with this group today on such an important and very relevant topic. As Laura mentioned, I'm a Managing Director at MST Services, and I am responsible for, among other things, our business development efforts. And to give a bit of background, I actually came to MST Services about 2 years ago because I was amazed at how much better life outcomes in areas like juvenile justice and child welfare can really be when families get a proven intervention like multisystemic therapy, or MST for short. And I wanted to play a role in really just getting more families and even more entire communities access to MST. Lori, who I will turn the presentation over to after I get through these introductory slides, is a rock star MST clinician. She's, as Laura mentioned, a manager of network partnership, the highest level clinical role in the MST model. She's been with MST Services for over 10 years and in the MST family for longer than that. So I won't take too long to get through my material before handing the floor to her. Next slide, please. So I want to start, for those that may be a little bit less aware of what multisystemic therapy is, to briefly describe the modality and its outcome. So MST at a very high level is a community-based, intensive, family-driven treatment that focuses on the entire ecology of the youth. And the ultimate goal of MST is to empower parents to make sure they develop the skills and resources needed to address the difficulties that would be arising in the future. This is all done through an intensive 3 to 5 month intervention where the therapist is on call to the family 24/7. And by working primarily with the family and empowering caregivers, the behavior changes are long-lasting and continue well beyond the 3 to 5 month intervention with an MST therapist. So bottom line is that the therapy works as shown via the outcomes, with 91% of youth living at home, 86% in school or working, and 87% without an arrest at the end of treatment. Next slide, please. To give just a quick snapshot of where MST is being delivered today, we have nearly 550 therapy teams delivering MST across 34 U.S. states. We're in 15 countries. MST has proven effective across a very large body of evidence that includes over 60 studies, 75+ million in research funding. There's actually constantly new studies coming out looking at various aspects of the model or outcomes. One interesting, fairly recent research study was a 25-year follow-up that actually looks at impact of an MST intervention on the siblings of the youth that were referred into the program. And that study, not that surprisingly, showed it to be very effective, that siblings of MST youth had a 40% lower arrest rate than siblings of youth who received an individual therapy. Now, a lot of the reason that MST has been able to deliver outcomes of this quality at scale is because of really the people like Lori Moore, who will be speaking in a bit, but basically because of the clinicians that work for MST Services as the quality assurance organization. So, and to give a little bit more color around that, when MST Services licenses a team, that team goes through an extensive program development process, which ultimately culminates in a 5-day in-person orientation training with their MST consultant. The MST consultant also performs a weekly consult with the team, so they're reviewing the ongoing MST caseload. The consultant also does quarterly on-site booster trainings. In addition, the families are called so that outcomes can be tracked and therapists can be tracked in their adherence to the therapy. So a TAM or therapist adherence measurement score is calculated. The supervisor is tracked in their adherence to the therapy model. Even really the expert or the consultant that the team works with is reporting up to a coach or an MNP like Lori and is being tracked in their adherence to the therapy model as well. So it's the entirety of this quality assurance process that allows us to say that the MST being delivered today across the country of Chile, for example, is the same MST being delivered in Louisiana and the same MST that was studied years ago in the clinical research trials, and that can get the same type of outcomes that really systems desire when they implement MST. Next slide, please. So MST's method of treatment also has a very strong evidence base regarding substance abuse, specifically as it relates to today's topic, with substantial reductions in substance use, 85% after treatment. And like other outcomes in MST, a long-term success rate with a 14-year follow-up study showing a 64% reduction in drug-related arrests. We actually saw last week that MST was one of only 12 programs that appeared on the initial list of programs that the Department of Health and Human Services is reviewing to be funded or to potentially be funded by the Families First Prevention Services Act, and the only program that's being evaluated in 2 of the 4 categories, so in both the mental health and the substance abuse categories. Next slide, please. So over the years, a number of adaptations to MST have been created to build off the success of the model to treat other patient populations. So everything I've talked about up till now has been primarily in the juvenile offender bucket, but we also have evidence-based models that serve child welfare, youth with psychiatric needs, emerging adults, incarcerated youth, and youth exhibiting problem sexual behavior. Next slide, please. So to give a quick snapshot into the MST adaptation that addresses child welfare, MST-CAN, or which stands for Multisystemic Therapy, Child Abuse and Neglect, and MST-BSF, for Building Stronger Families, they already have a significant evidence base for preventing future incidents of abuse or neglect. And these are interventions where the primary referral behavior is based on that of the caregiver as opposed to the youth. And they're interventions that are even more intensive. So they're typically lasting 6 to 9 months. There's extra clinical personnel on the MST team. So there's a crisis caseworker, 20% of a psychiatrist time. And these models, particularly BSF model, are specifically able to address families where there's caregiver issues or substance abuse issues and keep those families intact, reducing out-of-home placement in either foster care, congregate care, group homes. Next slide, please. These outcomes, 95% without further incidents of re-abuse, 86% with youth living in the home, 91% with no PTSD, show how effective this intervention is at dealing with these hard to treat cases, and why either MST, MST-CAN, MST-BSF can be an effective intervention to keep families together or intact, whether there's a host of issues, but a substance abuse issue with the youth or the caregivers themselves. So I'll now turn it to Lori Moore to run through the next few sections of the presentation.
Next slide, please. Thanks, Logan. And so, as Logan said, I'm Lori Moore, and I work with him at MST Services. And I like to tell folks that I'm from the state of Pennsylvania, where we don't always like to say all the different vowels and words, and where we like to talk really fast. So I'm going to work really hard not to do that today. We're actually going to shift gears for a couple of minutes and think together about the opioid crisis itself. After more than 10 years of rising death and abuse rates, there's little debate we are facing a health crisis centered on the use of powerful opioids. For us as practitioners and policymakers, we must understand this crisis we face, and we must seek solutions that will make a difference in the lives of the children, youth, families, and communities we serve. The numbers that you see on your screen reflect the current data provided to us by the U.S. Department of Health and Human Services. I know that we've all seen these numbers or numbers like them in some form or fashion. Today, we just wanted to take a moment to ground you in this data as it punctuates why this is being labeled an epidemic and really why we're here talking about this together today. From a report that was given out of 2016 and 2017, we learned that over 11 million people misused prescription opioids. We also saw during that same time period that over 2 million people were diagnosed with an opioid disorder, and over 800,000 people reported using heroin. And alarmingly, we also learned that 130 plus people died every day from an opioid-related drug overdose. As if these statistics were not concerning enough, the Health and Science journal STAT predicts opioid overdoses will claim nearly 500 to 650,000 lives over the next decade. So we know now, based on this data, that there is a need for effective treatment. And as Logan described, MST is a treatment that will be able to help fill that void in many communities. Next slide, please. With these alarming statistics, we often find ourselves being asked the question, how did we get here? Experts will tell us that there's no one simple answer or no one thing that actually created this epidemic, but rather there are many things. And so we've included some of those for your consideration. The first is, though the overall number of prescription rates have actually gradually decreased in the last 2 decades, the number is still staggering. Current information tells us that the number of prescriptions for opioids has escalated from 76 million to 207 million from 1999 to 2013, with the United States being the biggest consumer. By the sheer volume of drugs available, we know now that not only those who are prescribed the drugs are using them, but in many cases, including children and teens, others have access. Most adolescents who misuse prescription pain relievers are telling us that they get them for free, either by a friend or relative. Adolescents are also further at risk because we're seeing an increase in prescriptions following sports injuries or dental procedures. And so despite this ongoing crisis, CNN reported on November 2nd, 2018, that the U.S. Food and Drug Administration approved a new opioid medication 5 to 10 times more powerful than fentanyl. Along with this trend, there's also been an increase in social acceptability for medication. Now, while many of us working in the mental health field advocate for stigma-free interventions, including medication, we actually do see that social acceptability has impacted the number of patients requesting and using opioids. As this has also been occurring, we've seen an aggressive marketing campaign by the pharmaceutical companies, which actually has led to a direct impact on the landscape of opioid use. And finally, we learned if they have trouble finding, affording, or getting a script to manage pain, many patients resort to a cheaper and more readily available option, heroin. A survey among people in treatment for opioid addiction featured in the American Society of Addiction Medicine, Opioid Addiction 2016 Facts and Figures, we found that respondents chose to use heroin simply because prescription painkillers were far too more expensive and harder to obtain. Next slide, please. So with all this doom and gloom, we don't want you to be left in a place that you're thinking, well, what is the hope? Because we do think that hope and help is on its way. In late October 2017, the White House declared the opioid crisis a public health emergency. The administration is seeking nearly $17 billion in opioid-related spending in 2019. Also in September 2018, the U.S. Department of Health and Human Services awarded over $1 billion in opioid-specific grants to help combat the crisis ravaging our country. And as Logan spoke about, looking ahead, we're really looking to the Family First Prevention Service Act, which is set to begin in October of 2019. And this act will allow states to use Social Security funds to provide funding to programs that are research-based and proven to be effective. And this money will really treat families at risk of becoming involved with the Child Protective Services. We really want you to learn more about the Family First Prevention Service Act, and so we've provided for you a link on the screen directly to a white paper that's on our website that will help you as you learn more. Next slide, please. One of the things we like to say is that as we look at statistics, we really want to think that behind every statistic is a young person, a child, or a family that's impacted by the crises. It's more than just numbers. And often these youth and families intersect with the juvenile justice and the child protective service system. And in today's climate of increasingly potent and increasingly accessible drugs, the juvenile justice system must recognize these youth and must support them with effective treatment from entry to exit. Next slide, please. And so to put some context to that, remember last month, if you were on the CJJ webinar, you learned about brain and youth brain development and that it continues to develop throughout adolescence. As we think about that and we think about substance misuse, it makes adolescents particularly prone to the negative side effects of substance misuse, as substance misuse can impair cognitive functioning, leading to learning disability and behavioral problems. Every year, over 300,000 youth are arrested for drug or alcohol-related offenses, making that approximately 20% of all juveniles arrested across the United States. We know that the dangers of substance use is disproportionately present in the juvenile justice system, where it's reported almost half of all youth who enter with a drug or alcohol-related problem. And then to just really compound this, over 70% of youth entering substance abuse treatment are also experiencing other mental health issues. Next slide, please. In recognition that many young people who enter the juvenile justice system will come into contact with the drug courts, the OJJDP recently released new guidelines for drug courts that include the following: increasing family engagement, school and community involvement in treatment, treatment for non-English speaking families, parental mental health options, support for evidence-based practices, and the move away from fees and detention. Think about what we know about how youth of color and youth from poverty are disproportionately represented in the juvenile justice system. If we can implement these guidelines, we can have a direct impact on how we work with them and their families. Next slide, please. So as we think about that intersection that we just talked about of substance misuse and how those young people are coming into the juvenile justice system, add that to what we know about the research from over 50 plus years of what really drives delinquency and drug use. And what we know is that it's determined by multiple risk factors that occur across all the ecologies that the young person is embedded in. So if you look at your slide, you'll see that we know that family factors such as low monitoring, high family conflict, factors in the peer group such as the young person associating with other law-breaking, substance misusing peer. In the school, if the young person is at risk for dropout or low academic achievement. In the community, if there's low supports, if there's increased transiency, and then even in the young person themselves, low verbal and low social skills. These have all been identified as risk factors, and these things, when put together, can really increase the young person's risk for being using substances. And so multisystemic therapy, as Logan introduced it to you, is an evidence-based, research-supported treatment model that is matched well to the OJJDP guidelines that addresses those risk factors associated with delinquency and drug use. I'm going to talk a little bit later about how we specifically address substance misuse, but I really want to set the context with how do these young people intersect in the system with which you and I work. Next slide, please. Unfortunately, we've also been seeing a similar trend in the child protective system. Next slide, please. A report from 2015 cited that 208,000 children were removed from their homes due to drug use by the parent or caretaker, accounting for about 1/3 of all removals. The data does not specifically say that these removals were due to opioid abuse, but most professionals believe that the opioid epidemic is a contributing factor. Unfortunately, when caretakers get hooked on opioids, they're unable to care properly for their children, and often this leads to children and youth becoming increasingly at risk of living in dangerous and neglectful households. The numbers tell us that infants born addicted to opioids has increased 5-fold in the past decade, and the rate of children and youth being hospitalized after an opioid overdose has doubled since 2004, with many of these occurring after the young child accidentally ingested their caretaker's pills. Next slide, please. And so we find some really helpful information that appears in an article by Tootin, Jones, Schaefer, and Sitzer in 2012. It tells us that caregiver substance abuse poses significant risk to children and is associated with a range of negative child outcomes, including mental health problems, poor school problems, delinquency, and early alcohol and drug experimentation. It's difficult to provide consistent nurturing care to a child when abusing substances. In some cases, impairment in the parenting is so severe, it's considered physical abusive towards the child or neglectful. The article goes on to tell us that parents who abuse drugs or alcohol are 3 times more likely to abuse or neglect their children than are parents who do not have a substance abusing problem. It's not surprising then, folks, that substance abuse by a parent is one of the leading reasons for Child Protective Services to get involved with families. The article also tells us cases involving parental substance abuse are among the most difficult for the child welfare system to address. Relative to other child welfare cases, children of parents who abuse substances are more likely to experience abuse by the parent or out-of-home placement in foster care. And once that child's removed and they spend time in out-of-home placements, they're actually more likely to experience the termination of parental rights. Given this information, for those of us who work in the juvenile justice system, we actually also care very much about parental opioid use, as it can place youth at particularly high risk. What we know is children whose parents use substance are greater at risk for themselves to use substances, and as we said earlier, this then actually puts the child at an increased risk for coming into the juvenile justice system, whether or not the family is involved with the child protective system. We also know that when child maltreatment is linked to parental substance abuse, children are more likely to be removed from their homes, and children who are removed from their homes and from their parental care and grow up in the foster care system, again, whether it's due to parental drug use or other things, those young people are at risk of drug use, and again, at risk of coming into the juvenile justice system. And also, there's now some evidence to suggest that these young people do not fare as well in the educational system as their counterparts. Next slide, please. So now that we've talked a little bit about the impact of the substance misuse on the family and where it may intersect with the child protective system, let's take a moment and ground ourselves in the research in this domain as well. Scientific literature tells us that much like juvenile delinquency, factors leading to physical abuse and neglect are complicated and interconnected. They involve multiple systems, from the family to the social ecology to the school. For treatment to be effective then for these families, it must be tailored to different family situations, and it must address the caretaker and the community factors that put the family and the child at risk. As Logan introduced, building off our core elements of MST, we developed 2 adaptations, MST Child Abuse and Neglect, referred to as MST CAN, and MST Building Stronger Families, MST BSF. These are two evidence-based, research-supported models that treat families who come under the guidance of the Child Protective Services. We're going to learn a little bit more later about the outcomes of these two programs, but what we want to underscore here is that kids experiencing both parental substance use and maltreatment, and sometimes being removed from homes, are most likely to put themselves at risk for being involved in the juvenile justice system and are likely to experience substance misuse. MST-CAN and MST-BSF can be considered in part prevention programs for later child drug use by reducing parental substance abuse, child maltreatment, and child removal. In addition, when young people are in these programs, if they're also experiencing substance misuse, they can be treated within the context of this program as well. Next slide, please. So now that we've talked about the crises and we've seen how it's intersecting with the systems that you and I work with, let's begin to think together about strategies to combat it. In 2017, the Department of Health and Human Services put forth a 5-point strategy to end the opioid crises using the best science and evidence base available to us to directly address this health emergency. This report provides us with specific areas to focus on and can offer those of us directly in the field some guidance as we seek to support our communities. I don't know about you folks, but I'm really looking for answers. And as I read this document, I found that it really put forth some ideas that I could start to think about and put into place. We don't, unfortunately, have time to go through the whole document, and I apologize for that, but we do have some time just to talk, to introduce you to each strategy, and then we'll talk a little bit more about prevention and treatment. So the first strategy, as I just labeled, is better addiction prevention, treatment, and recovery services. If we can identify those treatment services that are going to really be available to people in the community where they live that address these problems as they're occurring, we can really impact this problem. The second is better data. And what we're really looking for is real-time data that as we gather it, it can impact the decisions that we make. Data decision-making is what we're really looking to do. The third strategy that they put forth is better pain management. And here they're really looking at using evidence-based treatment for pain management. So again, we can help folks from getting addicted or using their opioid prescription medication inappropriately. The fourth strategy is better targeting of overdose reversing drugs. And so this strategy is around the Narcan and drugs like that. And what we're really learning is how do those drugs actually impact the crises, and how do we get those into the hands of the people who treat the people who are overdosing, to families? How do we really make it accessible, and what will really work for those families? And then the last is really cutting edge research. We need to use research to help us make good decisions, sound decisions about pain management, about treatment, about how we're really helping our communities. We've provided at the bottom of this slide a link to this report, and we hope that you'll go and look at that and really think about how you can use those strategies as you're working in your communities. Please go to the next slide. And so the first strategy is around prevention. And so we're going to talk just a couple minutes about prevention. Next slide, please. So a critical piece for addressing this epidemic is to start with prevention. And so we want to think about what are characteristics of effective prevention programs. And we really want to underscore that effective prevention will target those risk and protective factors that we talked about earlier. So we want to be thinking about prevention strategies that improve knowledge and beliefs and attitudes and skills. We want to be using prevention strategies that use strength-based approaches. We want to use strategies that incorporate interactive, hands-on activities. Thinking about using prevention early with young people and thinking back to our brain science, we really want to engage those brains in active learning, and we really want to get them thinking about the decisions that they're making and helping them learn about skills that they can use when they're making those decisions. We want to address the multiple contexts of development. So we might be thinking about doing things in the schools and in the communities. And also prevention really needs to include enough time, weeks and hours to have impact. Many prevention programs they'll go through the prevention and then they'll come back and they'll do some booster trainings. What we find is kind of one-off, so an assembly or kind of doing perhaps a competition where it's just something like kind of like a one and done is really not going to prevent this problem. It's really those prevention strategies that come back and really reinforce the learning. Next slide, please. So going back to the Health and Human Service Department, they've also taught us about implementing science-based education campaigns. And so one of the best examples I can give to you here is, think about a commercial that I'm sure that you've seen on TV. The commercial opens up with an adult opening up their medicine cabinet and pulling out their prescription bottle and looking at the label, and they're taking out the bottle, and then they're closing the cabinet. And as they close the cabinet and you begin to see the mirror, you suddenly see that that adult image suddenly moves to being an adolescent image. And the tagline is something like, "Do you know where your kids are getting their medication from?" This is really a very nice education campaign, because what it's teaching families is that young people are getting the medication from families or getting them out of medicine cabinets for free. And we really need to help think about how we're storing medication and how we're discarding medication. In addition, they also wanted us to think about increasing and supporting the use of school-based and community-based prevention programs that are evidence-based. Linking back to the slide that I just presented, we really want to think about where do families live? How can we get prevention into the communities? I mean, how can we use evidence-based prevention so we know it is going to have that sustainable impact? And then the last one it identified is identifying individuals who are at risk for potential for opioid use or disorder, and make available prevention and early services. And one of the things I found really helpful was in the National Council of Juvenile and Family Court Judges, the judges really talked about needing to identify people who are at risk early. And if we can identify those people, and if we can get them into prevention and we can get them into early intervention services, we can really make an impact. We can stem the tide of this crisis. Next slide, please. So now I've talked about prevention, and I want to move into effective treatment. Next slide. So effective treatment really needs to target the origins of those problems. So go back to the beginning when we talked about risk factors. If we can use evidence-based models to really address the risk factors that are driving substance misuse, we can really get at this problem and we can combat it in a sustainable way for adults and adolescents. Next slide. So as I said, I really found it helpful to look at the Health and Human Service Department, and looking at one of the things, or some of the things that they have said about effective strategies and treatment. One of the things they identified is we need to enable individuals, families, and caretakers to find, access, and navigate research-supported, affordable treatments. And it really is about finding those affordable, evidence-based treatments and putting them in the home and in the community where the social support exists. It also talks about identifying and disseminating best practices related to medication-assisted treatment and putting that up with other mental health treatments. So we're not just addressing the pain management needs, but we're also addressing perhaps underlying mental health concerns. It also talks about targeting workforce development, providing training and recruitment incentives to underserved areas, and going back again for the population that we often find represented in the juvenile justice system. If we can really help those young people get involved in pro-social activities, if we can help them find jobs, help them find careers, we can actually then help them move away from substance abusing peers and a substance abusing lifestyle. And the last strategy I want to identify here is enable family-centered treatment that endeavors to keep families and caregivers together in the home and in the community. What I want to emphasize here, folks, is we're really looking for ways to keep families and young people at home safely. We want to target this in a way that we know everyone involved is safe, and we're really getting at the root causes of this problem. Next slide, please. So I want to match some of those ideas that I just presented to you with multisystemic therapy. And as Logan said, we're a research-proven intervention that gets results with substance-using young people and caregivers. Next slide, please. So as I share the foundation pieces of MST, I want you to think about the core tenets of the CJJ and how we're working to improve the outcomes for youth and families. Core tenets like ensuring school engagement, promoting the role of prevention, engaging youth, family, and community, diverting youth from penetrating further into the juvenile justice system, working to eliminate racial and ethnic disparities, and thinking about the special needs that individual youth may have and how we can help communities come up with an array of programs, an array of community-based programs that are going to meet their needs. And so as we think about those tenets and we think about MST, I just want to remind you that for an MST, we look at the entire ecology as our client. So we're addressing those multiple risk factors. So we're addressing things that are occurring in the family, the school, and the community. And we really want to think about the family's strengths, and we want to think about the family's culture, and we want to think about the family's community, and we want to leverage those strengths to actually help the family be empowered to be those long-term agents of change. We want to create this in a more sustainable way, and often we do this very different than typical treatment that's done that focuses solely on the adolescent, because we're really looking to change the ecology that surrounds the child and really help that child respond. As Logan said, we work for MST Services, and our responsibility is to provide that quality assurance. And so we're really helping programs adhere to the MST model. Next slide, please. From an MST perspective, we believe families are the solution. We believe families are the key to changing the young person's life because they're the most influential in the child's life. We can only work if we can effectively empower the youth caregivers with the knowledge, skills, and resources to effectively raise their child. We assume that families are doing the very, very best they can, and our job is to really understand why their best efforts aren't yielding the results that they'd hoped for. We really want to leverage those strengths, as I said, and we want to empower the caregivers to overcome the challenges that they face. Next slide, please. And so a moment about the nuts and bolts of how we address youth substance abuse. Next slide, please. So you're not going to spend very much time with an MST person without hearing us say, so what's the fit of that? And really, I tell people the fit is how an MST therapist's brain thinks. It's our assessment process. And what it is we're really looking at the problem from a multisystemic way, and we're trying to understand why does that problem make sense. And so specifically for substance misuse, we're wanting to understand the impact of the substance and how it impacts the young person's life and the ecology. We're looking at determining the frequency, intensity, and the duration of use. We want to find out where, when, and with whom the young person uses. We want to learn what triggers their use. And we really want to find out what kind of consequences that are going to be effective to stop their use. And really, we're wanting to change that natural ecology so we can support the family to sustain those changes long after the MST therapist is gone. Next slide. Once we understand the fit assessment, we're actually then going to move into tailoring our interventions to focus on the young person with the caregiver in the lead. And as Logan said, we're really about empowering the caregiver to implement those changes in the community where the young person and the family lives. And this can be a really different approach than other outpatient drug treatments do, because we're really not working to bring substance abusing peers together, because the research has actually demonstrated that that can have a harmful effect on them. And if you want to find out more about that, you can read in Deshawn, 1999, or Rual, 2005. But really, the concept we have here is called deviancy training. And it really tells us that when young people are placed together with other antisocial young people, they actually learn more negative things. So they might learn about different drugs that they'd never thought of, or they might learn where drug dealers sell drugs in their community that they didn't know. And so it really is that idea that the strongest predictor of drug use is affiliation with other substance misusing peers. And so we want to spend our time pulling the young person out of the substance misusing peer group and helping them find pro-social and positive things to do to fill up their life. Next slide, please. And so you're going to hear us talk a lot about strong engagement, and it's critical for us to be successful in MST to engage the young person and the caregiver. We can achieve about a 98% of a completion rate. And if we go back to our prevention slide, it's really important that young people get the dose of treatment that they need in order to be able to live that abstinent life of substances that we're talking about. Next slide, please. The other area I want to speak to is we also incorporate contingency management. And contingency management is one of the most extensively researched and best validated interventions in the field of substance misuse. All of our MST teams are trained in using CM. We can use CM what we call a la carte, where we can pick a specific intervention in the CM model, or else we can use CM with what we refer to as full cloth. And it's really going to depend on what's clinically indicated by what we learn about regarding the substance misuse fit for the young person. We incorporated CM into MST after we did some extensive research in drug court. We found that we could improve outcomes for the young person in the reduction of substance, and we actually found that we could accelerate the decrease in the substance use by using CM. Next slide. And so just really quickly, the core elements that our therapists are trained on is one, the ABC assessment, which is similar to gathering a sequence of events. So the antecedent, the behavior, and the consequence. And under the behavior, we not only want to know what substance is a young person using, but to what length does a young person go to get those substances? So how do they get the substance? Again, thinking about opioids, where are they getting them and how can we interrupt that? CM, like MST, relies on testing with objective measures. So we teach our caregivers to do those objective measures. And then we build what's called a family drug management plan, including drug refusal skills training. We develop point and level systems, and that's really akin to behavioral management planning. And to round that off, we make sure that we're teaching the young person refusal skills and any other social skills they need. Again, strong focus on that engagement and sustainability. Next slide, please. So CM and why we incorporate it in MST is it's very compatible with our model. It's consistent with our theory of change. It addresses those key risk factors that we identified, improving family functioning, decreasing contact with substance misusing peers, and that measurable outcome. And so we really want to incorporate CM to make sure that the young people are getting the best treatment possible. Next slide, please. So I also want to talk to you about how we address adult substance abuse. Next slide, please. And so much like adolescent, we're going to do that fit assessment. And with the adult, we're going to understand what are the circumstances surrounding the parental substance abuse. And here we might also be looking at and helping the therapist assess the potential risks for infectious diseases. So where there might be risk of HIV or AIDS, hepatitis B or C, or tuberculosis, really helping us identify those health risks. We're also thinking about the effects of the drug itself. Many adults have long-term effects from substance misuse. We're thinking again about that social ecology. And then with the adults, we're also thinking about the impact potentially of trauma and other mental health concerns. Next slide, please. Once we understand the fit assessment, we're going to tailor those interventions to match that fit. And because controlled research provides no evidence that more restrictive settings are safer or more effective in decreasing drug or alcohol use in the short or long term for adults, MST relies on those same proven and promising methods to treat adult caregiver substance abuse via a home-based treatment model. And remember what I said earlier in the presentation, we really are thinking about safety for the caregiver and safety for the whole family, the child, everybody. So interventions we might use could center around cognitive behavioral strategies. Again, understanding the sequence of use, altering the cognitions around the use. So we really want to understand what's the permission-giving statement that an adult might say. Skills training, behavioral reinforcement. Again, social ecological change. Here with adults, we might be also thinking about detox and how to safely help in the most medical safe way to help the adult detox. And then relapse prevention. In MST, we normalize relapse prevention. We don't commonly say if a person is going to relapse, we say, when will a person relapse? We find that if we normalize it, we can help them plan and predict it, and then they're not caught off guard when it occurs. Next slide, please. And so I'm going to turn it back over to Logan now, but I want to thank you for listening to what we know about this epidemic.
Thanks, Lori. I'll now spend just a few minutes going into a bit more depth about some of the substance abuse specific outcomes related to MST. Next slide, please. So as stated earlier, MST-CAN and MST-BSF are models aimed at the child welfare space that can successfully keep families together in case of caregiver abuse, neglect, or maltreatment, or if this abuse or neglect is caused by substance abuse. These therapies ultimately reduce future instances of abuse, neglectful parenting, psychological aggression, and most importantly, reduce the need for out-of-home placement. So as you can see, compared to comprehensive community treatment, MST resulted in half the number of youth needing to be placed. Next slide, please. These results are long-lasting, as is the focus of all of MST interventions. So we highlighted evidence from a 4-year study and a 14-year study to illustrate the point that this intervention can significantly reduce future substance abuse and the problems associated with it, like future violent arrests, and fundamentally just keep kids home, in school, safe, and out of trouble. Next slide, please. One element of MST that is a great contributor to the outcomes that we have spoken about is the ability to get families to complete treatment. There's a motto that's very well known within MST, whatever it takes. And this is most evident, I think, in the work done on the front end to engage families. These can be very difficult to engage families. And that is something that's highly prioritized in MST and is reflected in the numbers shown on this slide, with 98% of families completing a full course of treatment in this study. Next slide, please. So we're often asked to quantify in dollars what an investment in MST can mean for a community, and for MST-CAN, child abuse and neglect, a recent study did that for us, noting that all of the outcomes that I've described associated with MST-CAN translate into a return on investment of $3.31 for every dollar spent on MST-CAN, or a net benefit of roughly $26,700 per family. Next slide, please. So we're obviously proud of our endorsements and have listed a few on this slide here that we particularly value. So MST is one of 3 programs selected out of over 1,400 programs that were reviewed by Blueprints for Healthy Youth Development for its highest designation of the Model Plus category. We've also been endorsed by NIDA, the UN, and SAMHSA as well. And what I hope Lori and I have given you today is a good flavor for what MST is, how it intersects with substance abuse, and more specifically, the opioid epidemic, and how we can definitely be a component of the solution. So implementing MST in a community is a very tangible step that can be taken to bring a part of this solution into communities that I think we all agree are desperately searching for solutions that can work. Next slide, please. So that wraps up the presentation. Lori and I are available for Q&A here in a moment. And if you aren't able, for whatever reason, to have your question answered during this session, or if you just prefer to follow up with us directly, we put our email addresses here at the bottom of this slide, and would definitely look forward to hearing from you. Thanks.
Thank you, Logan and Lori, so much for that presentation. I just want to remind the audience to submit questions to the question box, and I will go through a few of those. So to start off, I have one question. This one is, does MST programs, what do you do for emancipated youth? So if there's a family, if they're estranged from their family or not close with foster parents, what do you guys suggest and how do you go forward with that?
So that for standard MST, as you're identifying, we need to have an established caregiver. If you go back to the slide that Logan presented on our adaptation, we actually have an adaptation called MST Emerging Adults, and that's actually for the population of young people who are typically aging out of the juvenile justice system or the mental health system, and it's an adaptation that can work with those young people who have substance misusing problems, mental health concerns. So it would be an adaptation that we would recommend folks look into.
Thank you. Next question I have is, when we think about how much money is saved, how much money per child does MST cost? So what's the upfront cost in the beginning?
Yeah, so clearly there's a huge benefit associated for communities to implement MST in terms of value. One, ultimate outcomes for that youth and their family, and then quantified into dollar savings in the community. That question is a little bit trickier to answer because it varies quite a bit from place to place, because so we at MST Services license organizations, not individual therapists, and so MST is delivered via a team of 2 to 4 therapists and a supervisor, and across the country, basically it can cost quite a bit more or less to get essentially master's level clinicians for their salary, benefits, fringe and administrative overhead to the ultimate provider agency that's delivering MST. But I think of it in the context of in whatever part of the country it would cost for 4 to 6 master's level clinicians at an agency with their salary, benefits, fringe, and other associated costs that of drive time or reimbursement to visit, to be in the community, seeing families and meeting with folks that they meet with via treatment, flex funds per family, equipment, office, things like that. And roughly, an MST team can serve 30 to 60 families per year.
Thank you. The next question is basically, what role, if any, does law enforcement have? So say, does law enforcement have the ability to refer a youth that they come into contact with to MST specifically, or is there no relation at all with law enforcement?
That is such a great question. So there is a great relationship between law enforcement and MST. So typically, our referrals do come from the juvenile justice system, so they might come through the courts, but we certainly want to have great relationships with police officers in our community. We train our teams to develop those positive relationships. We want our families to have positive relationships with law enforcement, because many times they're the folks who are kind of having that first entry-level conversations with young people or with families. And so they have a great influence in helping the young person, helping the community.
Awesome, thank you. One other question we have is, what does MST look like in practice when you want to keep youth with their families in a community that fosters a higher use of drugs or crime or such of low income and impoverished communities? What does that look like in practice?
Again, such a great question. So if you go back to the slide that I talked about, finding the fit, when we do that fit conceptualization, we're really going to look at what are those community factors. And so where is the access to drugs? And then we're also going to look at what are the protective factors. So who all in the community, such as the law officials, the policemen, who wants to help the community move away from being substance misusing. And so we're going to try to use those protective factors to help the young person get involved in pro-social activities. So it really might be helping them get back into school or getting into an education environment that's going to work for them, really helping the caregiver monitor the young person, know where they're at, who they're with, what are they doing. So we're really looking at how do we understand the community, how does the community impact this problem, and then what are the strengths of the community that we can leverage off of for change. There have been times when we've had young people go and stay at a relative's for a while in order to help them, get clean. There have been times when we've had relatives come and stay with the family in order to help for safety. So it really does depend on the family. We really want to think about the strengths of the family, the strengths, we want to leverage off those, and we really do want to think about the risk factors and help the family address those risk factors. So there's no one way it's going to look like. What it's going to look like is how do we tailor that intervention that really is going to match the context of the family and the young person.
Awesome, thank you, Lori. For the last question we have is, for how many of the clients in your research have been addicted to opioids? Or do you know that answer?
So we have, right now we have some research pending for the MST-BSF. And so if whoever sends that, asks that question, if you want to send me an email, there's some information we have specifically about the amount of caregivers in that research project that were opioid dependent. Other than that, we don't have any specific other data really just beside that research project that will tell us that information.
Awesome, thank you. Well, thank you again, Lori and Logan, for doing this wonderful webinar. And thank you to our participants for participating, and everything along with this recording will be online tomorrow. Thank you.
Thank you for having us.
Thanks.